Good morning. I am here to explain about this. Mr. S, a 32-year-old male from Jharkhand, presented to attended the medicine OPD with history of difficulty in raising upper limb, especially encountered while reaching for objects placed overhead, and he also gave history of stiffness or locking of hip while he was attempting to walk, and generalized tiredness and excessive daytime sleepiness. When asked further, there was no difficulty in holding objects, but there was difficulty in releasing objects from the hand, and there was no history of frequent fractures or fall, no history of difficulty in mixing food, buttoning or unbuttoning shirt, and no history of paresthesia or breathing difficulty. He had a poor scholastic performance, and these symptoms were first noticed around his 15 to 17 years of age, gradually worsened since then, and the onset to peak was about 7 years. His father also had similar phenotype, expired at the age of 44 years. Father had a hemiplegia at 42 years of age, and siblings, he had 2 brothers and 1 sister, and the siblings have no complaints. On examination, he was hemodynamically stable with a blood pressure of 120/80, the pulse rate of 78 per minute, regular in rhythm, with a respiratory rate of 16 per minute. He was pale, no icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy noted. He was in a short stature of height 145 centimeter with a weight of 33 kg. On middle examination, there was no brachydactyly. However, there was frontal balding present and temporal wasting present, and mild ptosis also present. There was high arched palate with crowding of teeth. Nipples are widely placed. Palmar piece was normal. No axillary hair, sparse pubic hair. Testes are at place, and there was calf muscle hypertrophy noted. Examination of the central nervous system showed he was conscious oriented and answers appropriately, but however he takes time to answer back, and he was lethargic in answering, and his memory was poor, especially when asked about recalling, and there was no cranial nerve deficits. And there was a examination of the motor system revealed bulkness of 17 centimeter in bilateral upper lung and 33 centimeter in bilateral thighs, and tone was normal in all 4 limbs. There was weakness in the shoulder and the hip with 3/5 power in the shoulder and 4/5 power in the hip. Other muscle powers were normal, and reflexes, bilateral triceps were 1+, other dependent reflexes are 2+, but there was no delayed relaxation time, and no sensory loss, no cerebellar signs, and no gait abnormalities particular to waddling or tilting. So the syndrome complex, there was chronic progressive symmetrical proximal muscle weakness, and I want to show him with his to you with his consent. And on examination, this finding was also noted. So I wanted to ask, what is that finding noted in the video, and what did the diagnosis you think of?
Can you show the video again, please?
Okay. In medical term. So moving on, the patient exhibited a phenomena of myotonia, and the syndrome complex is further refined as chronic progressive symmetrical proximal muscle weakness plus myotonia. So looking into the muscle weakness, and it's the first thing is to identify the pattern of weakness on a clinical examination and to localize in any of this group. My patient had a proximal more than distal weakness. So considering the differentials to this were a list of proximal limb girdle weakness, like most dystrophies are congenital myopathies or metabolic myopathies, mitochondrial or inflammatory myopathies, toxic myopathies, and some endocrine myopathies. But additionally, the patient also had myotonia, so that the syndrome, the differentials were narrowed down further based on the myotonia. So looking into myotonia, it is the impairment of relaxation of the skeletal muscles after voluntary contraction. And the differentials consider this myotonia could be either associated with dystrophic or non-dystrophic. Dystrophic are mostly due to the myotonic dystrophy type 1 and type 2. Non-dystrophic may be due to myotonia congenita, which is a chloride channelopathy, or hyperkalemic periodic paralysis, which is a sodium channelopathy, or it could be a other sodium channelopathy, paramyotonia congenita, potassium aggravated myotonia, or perlecan, a proteoglycan involved in bone formation and muscle formation, which is impaired in Schwartz-Jampel syndrome. And this myotonic dystrophy is further of two types. Type 1 is where normally the CT repeats in the DMPK gene in the chromosome 19 was normally expected is 5 to 37, where in this type of type 1, there will be more than 50 CTG repeats, whereas in the type 2, in the chromosome 3, the CCTG normal repeats expected is 10 to 13, whereas in type 2, it will be more than 75. And this syndrome can be clinically picked up like the type 1 patients will have frontal balding, temporal wasting characteristic known as the hat's head faces. And the type 2 patients will be having more proximal limb weakness with disabling or atypical pain, but milder systemic involvement. And the myotonic dystrophy is not only localized to the musculoskeletal, however, it also includes multi-system involvement. Like in the cardiac system, it can cause various degree of conduction blocks and arrhythmias and even sudden cardiac death. And they are highly characteristic cataract present in them is the Christmas tree appearance. And with the central nervous system, there will be behavioral cognitive decline, memory disturbances, or altered sleep habits, or excessive daytime sleepiness also. In endocrine system, there could be testicular atrophy, balding, erectile dysfunction. And the patient will also have GI symptoms like constipation, gallbladder stones, elevated liver enzymes, and they are highly prone for risk of thyroid gland, choroidal melanoma. This patient had with historically and clinically had memory disturbances, daytime sleepiness, balding, those things. So after this, I explained the patient that there is a possibility of a myotonic dystrophy that the patient could have, and it's very clinical manifestations and its outcome. So, what are all the multi-system involvement could be expected? So the patient wanted a limited evaluation to confirm the disease. So according to this, the proximal and with the myotonic, we should confirm with the EMG. And this patient's EMG showed features of myotonic dystrophy. At the review visit, the patient was brought along with his family, and a detailed family meeting was held, in which the patient psychological and supports offered by the family is much more needed, and the extensive investigations are planned. So in the treatment, it is a multimodal approach. Membrane stabilizers can be used for mexiletine and phenytoin, and associated conditions to be identified and addressed in this group of patients. So my the take-home messages which I want to suggest is, whenever we see a patient of weakness and with the characteristic facial features, actually I identified this patient by his facial features only, that hatch head typical pattern. Then I specifically asked for any difficulty in releasing objects, and he agreed to that. Then I checked for the myotonia, and there was also percussion myotonia that I couldn't get you here, and also look for extra. So identify this patient and suspect the patient that he may have this, and with extra muscular features, cataract, balding, diabetes, cardiac arrhythmia, or infertility. How to diagnose? By the EMG study and by the genetic analysis of the CTG repeats and CCTG repeats, which I explained to the patient and his family, and they are willing to do it on later dates. And always anticipate as this occurs in successive generations with a phenomenon of anticipation. Thank you.
That's a nice presentation. Do you guys have any questions regarding myotonia? Maybe I'll ask one. How is the long-term prognosis? How do patients do in general? Do you have any data, any case series, anything from?
Type 2 do better than type 1.
Okay. But we don't have any case series to show us. Maybe next presentation.
Sure.
It's it's good to know, isn't it? there may be a case series from India or from Vellore here. You can show us and we will know what kind of presentation, how long they do, what kind of complications, they have. Yeah. What about others? Any questions? So you don't see it very often. So, it's nice. You saw the clinical
Had
those features and then you suspected it. Good. Okay. All right. We'll move to the next presentation.